we started to talk about the antibacterials, and we finished talking about the cell wall synthesis inhibitors. Right? I want to remind you we have three types. We have beta-lactams that inhibit transpeptidase, formation of the linkages between the peptidoglycan chains. We have glycopeptides like vancomycin that prevent addition of new residues of NAM or NAG, and we have bacitracin that prevents elements of the cell wall, the building blocks, the fragments of peptidoglycan, to be transported across the plasma membrane. We discussed that some of those drugs are narrow spectrum. Most of them are narrow spectrum, focusing mostly on gram-positive microbes, right? Because it makes sense. Gram-positive microbes have thick cell wall, right? And by inhibiting its synthesis, cell can be lysed fairly easily. Okay, so you see the missing links. Okay. But some of them, like last generation cephalosporins and bacitracin, have the broad range. So they are quite effective. Sorry about that. Quite effective in targeting both gram-positive and gram-negative microbes. Next class of antibiotics that we're going to talk about is drugs that inhibit protein synthesis. And they do so by binding to the bacterial ribosome. We've discussed before that bacterial and eukaryotic ribosomes are considerably different in terms of the structure. And since they are so structurally different, there's a good opportunity to design drugs that will specifically bind to bacterial ribosome, but not to the eukaryotic. Therefore, and there are drugs like that, we're going to talk about them, the drugs that bind to the bacterial ribosome have high specific toxicity, which means that they inhibit protein synthesis in bacteria, but not in eukaryotes, I mean humans. So it means fairly acceptable level of side effects. Most of those drugs are either natural, such as aminoglycoside, for example, or lincosamides, or semi-synthetic, so modified versions of the natural drug. The only exception is the class of drugs that is called oxazolidinones. You're going to see a lot of funky names now, and don't blame me for those funky names. Blame organic chemists that name chemicals in a certain way. Okay, it's some of those names are tongue breakers. There are, here you can see 5 classes. Oxazolidinones are not in this picture. So there are 6 major classes of the drugs that inhibit protein synthesis. Drugs such as aminoglycosides and tetracyclines bind to the 30S subunit of the ribosome. Drugs such as chloramphenicol, different macrolides, which include drugs like erythromycin, and lincosamides, like clindamycin, bind to the 50S subunit. Oxazolidinone, as you will see, has a fairly unique mechanism for inhibiting the protein synthesis. Here I tried to summarize the mechanisms, and I mentioned on Monday that for this chapter, for this part, what you really have to know is recognize the name of the drug. I will not ask you to list me, I don't know, at least 3 aminoglycosides. Don't worry. On the exam, it's not going to happen. Okay? If you don't have an actual source, I'm not going to ask you this. But you have to recognize the mechanism by which those drugs work. So first we're going to talk about two drugs that bind to the 30S subunit. The aminoglycosides, such as streptomycin, gentamicin, neomycin, kanamycin, and tetracyclines. You all know tetracycline. You probably have run into the drug known as doxycycline. Aminoglycosides bind to the 30S subunit, and what they do, they change the conformation of that subunit. They tweak it. I don't know how to say it. They pretty much change the subunit in the way so that proteins that are being synthesized become faulty. Not the right amino acid is inserted. Does that make sense? Okay, so the ribosome doesn't put the right correct amino acids in the protein. Primary structure is altered. The entire structure of the protein is also altered. And if structure is changed, what happens to the function? Right, function is altered, and believe me, it's something like, think about when you try to assemble something, like you bought a piece of furniture from IKEA and you didn't put the parts in the correct fashion. It's not going to work. In a very brief statement, it's not going to work. Same here, it's not going to work. Does that make sense? These were first broad-spectrum antibiotics. First aminoglycosides were developed by Salman Waxman in the mid-40s. And these drugs are actually bactericidal because some of those faulty proteins incorporate themselves into the membrane, okay, and membrane ruptures. They destabilize the membrane. Later, the class of the protein synthesis inhibitors called tetracyclines, which bind to the 30S subunit and prevent tRNA from binding to the ribosome, was discovered. Now, these drugs are not bactericidal at the therapeutic doses, they're bacteriostatic. But the great advantage of tetracyclines is the range. These are antibiotics with the broadest spectrum of effects. If you would look up treatments for virtually every microbe, from Mycobacteria tuberculosis to gram-negative pathogens of the urinary tract, to obligate intracellular pathogens like rickettsia or chlamydia, treatment options will include tetracyclines. Of course, the effectiveness will vary, but for infections with obligate intracellular parasites, like bacterial parasites like chlamydia or rickettsia, tetracyclines often are the only option. Okay? 50S subunit of the ribosome provides more options for inhibition of the protein synthesis. And there are 4 different types of drugs that, well, okay, let's say 4 different types of drugs that bind to 50S. Macrolides that include such a well-known drug for you, I think, as erythromycins and azithromycins prevent the ribosomal translocation. They essentially stall the ribosome at one place. Does that make sense? Okay, so ribosome cannot move along the RNA molecule and protein synthesis is stopped. They're also bacteriostatic, and broad range antibiotics. Linezolid, like clindamycin, a bacteriostatic with a fairly narrow range of effect. Okay, they can treat gram-negatives and some gram-positive infections, and they not presented on the scheme, but they bind to the 50S subunit, and they cause premature dissociation of tRNA with peptide. Does that make sense? You know, I'm a sucker for analogies. So imagine that you're cooking something and you're like in the middle of the process. I don't know, you're making a cake, so you mix like flour and milk and eggs and whatnot and mixed it all up, and you tell your guests, well, the cake's ready. You didn't even put it in the oven. Same happens here. The protein synthesis is stopped prematurely, protein is dysfunctional, and the cell cannot grow anymore. Does that make sense? And last drug is chloramphenicol that I want to mention in this particular group. So chloramphenicol prevents the formation of the peptide bond between the incoming amino acid and the growing polypeptide chain. So it's inhibitor of peptidyl transferase, official name for it. All of these drugs, streptomycin, tetracycline, clindamycin, chloramphenicol, erythromycin, azithromycin, they are on the WHO list of essential drugs. Are you familiar with that? You've never heard of it? So WHO, World Health Organization, maintains and keeps up the list of essential medications that must be available for a reasonable price at any market. Which means Viagra is not on that list. Chloramphenicol is, because it's essential for treating life-threatening diseases. Does that make sense? Okay. Oxazolidinones are synthetic drugs. One of the great examples of them is Linezolid. They have broad range of microbes that which growth they can inhibit. Interesting thing about Linezolid is that it doesn't bind to the, strictly speaking, it doesn't bind to the ribosome. It prevents the ribosomal formation. It binds to the 50S subunit, so the ribosome cannot even assemble. You see the difference? Yes. I think that why you use it specifically against staph, so it's a broad spectrum antibiotic. But a lot of gram-positives are resistant to many drugs, many antibacterial drugs that we have. They're pretty much going to be resistant to all derivatives of penicillin. Great likelihood that they're going to be. Do you have a question? It's fine. Ask me if you have a question. I may not have an answer, but you can ask. No? Well, good that you ask. Don't hesitate to ask. I'll tell you what you need to know. So gram-positives, resistant, very resistant, not only to cell wall inhibitors, but also to these guys. Linezolid, and I was about to say this, Linezolid is often considered as some kind of quote-unquote supplemental antibiotic. If nothing else can treat, then we're going to use Linezolid. And it allows us to maintain the fairly low levels of resistance to it in the population of microbes. But it will be used more and more because microbes become more and more It's they supplement the major therapy mostly with linezolid, or they use it. It's quite effective against Mycobacterium tuberculosis. So they try to limit the usage of that drug to keep the resistance low. What you have to know, I'm not going to ask you to describe like in essay questions. You won't have to describe in details what is the exact mechanism. But I can ask you, the tetracyclines inhibit protein synthesis by binding to 50S subunit and preventing formation of the peptide bond, which is wrong. Binding to 30S subunit and preventing tRNA, binding of incoming tRNA. That is right. So you have to match the drug and the described mechanism in the question on the exam for each class of a drug. So I will avoid questions something like clindamycin or erythromycin. I will ask about the class. Does that make sense? But you may get a question, doxycycline belongs to. I try not to trip people over. So you won't have to pick up tetracyclines. Well, it's pretty much kind of obvious. Because it definitely, doxycycline belongs to tetracycline. So you have to recognize major drugs. Okay? I will not ask about any drug that I haven't mentioned in the lecture. Okay? Does that make sense? Like I mentioned actinomycin, neomycin, and streptomycin on several occasions. I expect you to know that those are aminoglycosides. I mentioned tetracycline and doxycycline. Well, I expect you to know that they are tetracyclines. Erythromycin and azithromycin, I expect you to know that those are macrolides. Clindamycin is lincosamide. So, like for oxazolidinone, you have to know that name. Because now you may, I was a student. I know how you feel. Believe me. I do. But when you come into the clinical settings, it's always better to show the knowledge. It's not a pharma class. We're not talking about pharmacokinetics, pharmacodynamics, bioavailability of a drug. No. But mechanisms, yes, I want you to know that. And without hesitation, that's probably the hardest portion. Seriously. That's the hardest portion of the drug part. Does that make sense? Focus on this. Spend some time on this. Okay? Is that clear? Any questions? Oh, no. It's for, no. We actually had a discussion with somebody yesterday. I think yesterday. Interesting fact, if you would look at the prices of this for the same drug in developing countries and in the United States, guess where the price is higher? Yeah, about 4 times. Yeah, my son was taking clindamycin for 6 months. It was $50 a month, and it was because we had copay, so it was more than 50. Yeah. So I had to shell out $50 because that was my copay for a drug. That was pretty considerable. Now these are my favorite ones because these are somewhat of a antimicrobial nukes. You know, like in military, you don't use nuclear weapons in the regular conflict. You know, if you start using nukes, things got serious, right? Same goes for drugs that disrupt the bacterial membranes. Can you tell me why? What is the structure of bacterial membrane? In 2 words. Phospholipid bilayer. That's it. What is the structure of eukaryotic membrane? In 2 words. Phospholipid bilayer. So they're not very much different. They're actually pretty much the same. Okay? So if you target a bacterial membrane, you're going to target eukaryotic too. There are 2 major classes of drugs that disrupt the membrane: polymyxins and lipopeptides. Huh? So chemotherapy. So you're referring to cancer? Chemotherapy, strictly speaking, the term is applied to any type of therapeutic intervention that is using drugs. When you go home and take ibuprofen, you are doing chemotherapy. We just don't use it on the regular basis. We usually refer to cancer. This is all chemotherapy. But the cancer drugs, they interfere with much more than just membranes. So these guys, polymyxin B, is the component of the topical antibiotic ointment or antibiotic cream. Does that make sense? If you read it, it's neomycin, polymyxin B, and something else. I don't remember. Polymyxin E, or the drug that is called colistin, is given orally, but it's prescribed in clinical settings on the very rare and unique occasions. The reason for that, obviously, is that it's so toxic. The toxicity of polymyxins and lipopeptide antibiotics is very high. Okay? So colistin is sort of a last resort to treat severe intestinal infections. So pretty much, you see, decontaminate bowels. We talk about killing everything in the bowels. Okay? In case of patients that are immunocompromised or patients that are at risk of contaminating tissues from the bowel microbes during the invasive surgery. It can be used IV for infections with multi-drug resistant bacteria. Okay, and daptomycin, the representative of the lipopeptide class, is used to treat MRSA. Okay, so you see, these drugs are used to treat severe resistant bacterial infections. Colistin, for example, has absolutely awful nephrotoxicity. It pretty much kills the kidneys of a patient. And about 3 or 4 months ago, I came across the paper. Well, it's not really a paper, it's more of a snippet of a news. Colistin-resistant gene was found in some gram-negative microbe already. So it's not the regularly used drug, right? But even occasional use promoted development of resistance. And think about this, it's a plasmid, which is bad, because plasmids are spread in the population much faster rates than the chromosomal genes. Does that make sense? So we're basically screwed. Okay, but generally speaking, the polymyxins are commonly used for topical treatment. Commonly used for topical treatment because they're so toxic. Nobody uses them They may, yeah, they may. Orally, yes, but it will wipe off everything. It pretty much, it's probably not going to make a patient completely germ-free, but to a large extent. But again, it's sort of a last resort if nothing else works. Does that make sense? It's really strong antibiotic, which is also very toxic. That's why polymyxin is used topically. Daptomycin has a fascinating mechanism. So polymyxins disrupt the membrane, right? They pretty much disrupt the outer membrane in gram-negatives, you know, and disrupt the inner membrane in gram-negatives, and so on and so forth. Does that make sense? The idea of disruption in the membrane. Daptomycin, in my opinion, is much more fascinating. So it's a lipopeptide, which means it consists of the peptide part and the lipid part. Okay? So lipid part is hydrophobic, peptide part is hydrophilic. Hydrophobic parts are inserted into the membrane, and it's not just one molecule of daptomycin. There are several of them, and they form a pore, a hole in the membrane, an organized hole, like a channel. And something is going to go through that channel very effectively. Ions. And when ions start to get out of the cell and go back into the cell, what changes? Membrane potential, yes. Membrane potential changes and cell becomes dysfunctional. It's really fascinating mechanism. I think it's wonderful. Okay, well, the title of that slide is Inhibition of DNA Replication. Strictly speaking, it's nucleic acid synthesis, I should say. So there are two major classes of drugs that interfere with the synthesis of nucleic acids. One is ciprofloxacin, and another is, fluoroquinolone, and another is rifamycin. So rifamycin inhibits RNA polymerase. Remember when we discussed the RNA polymerase structure and function, I told you that it looks like an open fist. Okay? And the DNA molecule comes through the pocket, an RNA molecule is churned out. So rifamycin, different rifamycins, like the drug like rifampin, blocks the release of RNA and effectively stalls the transcription. Does that make sense? It's a very effective anti-TB drug. Really, really effective anti-TB drug. Okay. Fluoroquinolones, as illustrated here, they bind to DNA gyrase. Okay. The enzyme, it's also called topoisomerase. Remember topoisomerase 2? The enzyme that prevents DNA supercoiling. When it's inhibited, DNA replication is stopped. And since DNA replication is stopped, cell dies. Now these drugs you probably have encountered. Cipro is the example of fluoroquinolone. It's a broad-range antibiotic, okay, used to treat a variety of systemic infections. Does that make sense? So here, what you have to know, rifampin inhibits RNA polymerase preventing transcription. So you have to make that step. Don't try to convince me that it prevents DNA replication. And fluoroquinolones inhibit DNA topoisomerase or DNA gyrase, those are synonyms, okay, stopping replication of the DNA. Okay. Now this, we're going to go back to the original, the old stuff. Remember we talked about the first synthetic drug, the sulfonamide, synthesized in Germany? So this is the class of drugs that is called sulfa drugs. This is the example of sulfonamide, but different sulfonamides have different residue side chains in the molecules. Like you've all heard probably about sulfamethoxazole, the antibacterial drug, the bacteriostatic drug. These drugs are structural analogs of para-aminobenzoic acid. Para-aminobenzoic acid is the initial substrate in the long metabolic pathway of synthesis for tetrahydrofolic acid. Tetrahydrofolic acid is then converted into the nucleotides. So you can appreciate that this pathway is critically important, right? Now, if you would look at the structure, look at this. This fragment is the same, this fragment is the same. So sulfonamide binds to the active site of the enzyme that converts para-aminobenzoic acid into the dihydrofolic acid. So if it binds to the active site, what type of inhibition we see here? It binds to the active site instead. Competitive, yes. So sulfonamides are competitive inhibitors of this enzyme. I'm not going to ask you the name of that enzyme. Don't worry. Okay? You're not gonna get a question. Sulfonamide inhibits this enzyme. No. But you have to understand that it's a competitive inhibition of one of the steps in folic acid synthesis. Did I make myself clear? Question. Please don't hesitate to ask me questions, because I want everything, my expectations, to be as clear as possible. Okay? Another drug that affects the same pathway is trimethoprim. Trimethoprim binds to the active site of another enzyme in the same metabolic pathway. Okay? That second enzyme is called dihydrofolate reductase. Okay? And blocks the synthesis of tetrahydrofolic acid as well. Okay? Does that make sense? So sulfonamides, say, let's use sulfamethoxazole. Okay? It's called sulfamethoxazole, SMX. Sulfamethoxazole inhibits dihydropteroate synthetase. Even I have problems saying that. Trimethoprim inhibits second step. So they can be used separately. But when they are used separately, they are bacteriostatic. So if you combine them, they're going to inhibit both of these enzymes, becoming bactericidal. Does that make sense? Pretty much, yeah. Well, yeah. So as far as I understand, the idea behind the bacteriostatic versus bactericidal in this case, if you block this, there's probably some detour, enzymatic detour. It still allows you to produce some nucleotides, maybe not as many, not as fast, so cell stalls in the growth. If you block this, there may be other sources for dihydrofolic acid that will let you to produce nucleotides. When you kill both, the cell is toast, because you cover pretty much all bases. You guaranteed you block this pathway. That makes sense? So please know that both sulfamethoxazole, sulfonamide, and trimethoprim inhibit synthesis of the folic acid, but they inhibit different steps in that synthesis. and that they bactericidal together, not separately. Another drug that is called isoniazid, which actually sort of a short name for the long chemical term, inhibits synthesis of mycolic acid. And there's a class of microbes that have mycolic acid in the cell wall. Class of bacteria that have mycolic acid in the cell wall. Mycobacteria. Okay? Like Mycobacteria tuberculosis, Mycobacteria leprae. So isoniazid is extremely effective against mycobacterial infections, but pretty toxic. And I mentioned the class of the drugs recently developed, diaryl quinolones. They inhibit ATP synthase. So essentially they suffocate the cell. Okay, they stop ATP synthesis, but they're pretty toxic because they can also affect ATP synthase, in the human cells. Does that make sense? Okay, now the coolest part. I get all so excited. In this case, I'm playing on the microbes team. Okay, against humans. Microbes get resistance. Period. It's inevitable. And probably the biggest take-home message that I will not ask about, it's kind of, it's more of a, I'm going to do sort of a motivational talk now that I hate. When you go to the hospital and work in the hospital, mechanisms, it's cool, it's really cool to know that penicillin inhibits the cell wall synthesis. I understand. It's awesome, really. But one thing that you have to think about all the time is resistance. Resistance. Are they going to develop resistance? Are they going to develop resistance? If I have a patient coming in with what looks like a flu, I should advise this patient not to take antibiotics. You know that paradox in the US healthcare system? When doctors see a patient with, I don't know, respiratory disease, doctors do the blood work, it's high fever, myalgia, no purulent exudate in the nose, no, purulent, any kind of pus in the throat, no white membranous formation, so it's definitely not a bacterial infection. It looks like a virus. Okay, no leukocytosis, virus. I tell, look, you have a virus. Go home, suffer, get better, get back to work. Nothing's gonna help you specifically. Just drink a lot of fluids, lay down. Okay. Oh, now they do. But the problem with patients is that, look, I am a patient, I come to the doctor, I am sick, I want drugs. And if they don't prescribe me antibiotic, I'm going to be pissed and I'm going to go to another doctor. So doctors often face a dilemma. Either be responsible and don't prescribe antibiotic, or saying, screw that, I want to keep the patient, there you go. You see, it is really a problem. Yes. Yeah, I came to the doctor, he didn't prescribe me anything. Although I must say, sometimes it goes a little bit too far. My wife went to the doctor with what looked by all means as the bacterial nasal infection. It wasn't too bad, but it was droning for quite a long time. And it was all signs and symptoms of bacterial infection. and she never has any allergy, ever. In her life, she's not allergic to anything. And PA says, oh, it's an allergy, go home. You don't need antibiotic. I mean, I appreciate that. She probably, she got better in 3-4 days without any antibiotics. But don't lie. Tell her, look, we can give it to you. It'll shorten your symptoms by a day. Let's just skip it. She would understand. But instead, that I was really pissed about that. Okay, now, resistance. What are the mechanisms? So to understand, I really want you to understand the mechanisms, how they work. Okay, so you look at this picture, okay, focus, please, not on which drugs, so which mechanism works against which drugs. It's not that important. Okay, don't focus. I'm not going to ask you what is the major resistance mechanism against fluoroquinolones. Okay, that makes sense? But I will ask you about the mechanism per se in some or another form. So you have a drug that binds to some kind of a target, right? And produces the effect. Are you following me with that? So, using that extremely primitive equation, let's see from the standpoint of microbe, how can we protect ourselves from the drug? Don't look at, we will refer to the scheme. So, what can you do? You're a microbe. You have drug that comes into you, binds to some target inside of you, and kills you. How would you protect yourself? Forget about medicine from the common sense standpoint. Change something with the target. So, change target. There you go. Target modification. Does that make sense? Okay? What else can you do? Look at the equation. It's more broad, but I want a specific action. Can you destroy the drug, hypothetically? Yeah. 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 You can inactivate the drug. If there is an enzyme that will break it down, perfect. Does that make sense? Okay. You can destroy it, right? Drug has to get into you as a microbe. Can you prevent it from getting into you, hypothetically? Yes. No penetration. Don't let in. If you ingested some bad food or too much alcohol, what is the best way to treat that? Cause vomit. Get rid of it, right? So if there's a drug inside of the microbe, can it pump it out? Hypothetically, again, all hypothetically. Technically, yeah. Efflux pump. So those are mechanisms of resistance. Does that make sense? They're pumps, like the pump, the protein, transmembrane protein that just specifically binds the drug and pumps it out using ATP for that. That's another interesting point that I want to make. We'll get to that. We'll get to that. And that's the right observation. So, drug modification, right? When drug is modified, question? If you still have a question, what you have to know, I'll tell you. Okay? If drug is modified, it becomes ineffective, like Remember we talked about penicillinases, the enzymes that break down beta-lactam rings? That's a great example. I'm going to use this as an example of what I may ask you on exam. I may give you a situation. Such and such microbe destroys the, aminoglycoside destroys the kanamycin, has an enzyme that breaks down the kanamycin. What type of resistance it is? Okay, and you have to recognize that it's a drug modification, not a target. Does that make sense? Does it make sense? So please be able to tell apart drug and its target. So penicillin is a drug or target? Drug. And its target is enzyme that synthesizes the cell wall. Aminoglycoside. Drug or target? Drug. And its target is ribosome. Okay. TMP, trimethoprim, drug or target? Drug. Its target is some enzyme here, right? Does that make sense? Okay. Let's say, hypothetically, I give you a question. Bacteria blah blah blahs blah blah blahs has an altered form of the enzyme that is inhibited by TMP. So the altered form is not inhibited. Does that make sense? So some bacteria, blah blah blah, whatever name is, alters the enzyme that is regularly inhibited by TMP. Will it be an efflux? No. Will it be a blocked penetration? No. Will it be a drug modification? No. It will be a target modification. Does that make sense? It changes the target for the drug. Does that make sense?
What about the inactivation of enzyme?
We're getting there. Oh, inactivation of enzyme. That's a poor word selection. Pretty much it's destruction of the drug. Does that make sense? When drug gets just killed. Okay, so drug modification, we got it, right? Prevention of uptake. Drug doesn't get in. Pseudomonas. Pseudomonas is freaking notorious about it. Pseudomonas has 3 or 4 different systems to protect itself from the different drugs. Okay? Follow me?
So is prevention of cellular uptake like blocked penetration?
Yeah, drug doesn't get in. I understand your concern. You express it more straightforward. What should you focus on? This or this?
No, I'm just trying to
Match?
correlate it. So when there's a question, I would understand what that means.
In terms of pure brutal memorization, if you want to just brutally memorize this, what I suggest, as Lauren does, relate these mechanisms as much as possible to the cell itself. Some of them, not all of them, are on this picture. Does that make sense? So try to relate it, it will help you to understand. So you can either prevent the cellular uptake or pump it out. In fact, Pseudomonas does both. It prevents drugs from getting in, and if they do get in, it pumps them out. Does that make sense? Target modification. Remember, we talked about penicillins. Penicillins bind to penicillin binding protein and effectively block its function. The microbe like MRSA has another form of penicillin binding protein to which penicillin doesn't bind really. Does that make sense? So they modify the target for the drug, so the drug doesn't work anymore. Does that make sense? I think I found sort of an analogy. Think about drug and, target, I'm becoming dyslexic, as the key and the lock. Okay? In order for drug to work against the target, lock and key should match. You follow me? If somebody changes your key, you're not going to open the door. If somebody changes the lock, you're not going to open the door. Does that make sense? Okay? Target overproduction. I love this method. You just make so much target enzyme that the amount of the drug is just not enough. For instance, if you go back to this awfully overloaded picture, and remember the inhibitor, say sulfamethoxazole, is the competitive inhibitor, right? It's a competitive inhibitor, right? If you overproduce the enzyme, some of that enzyme will still be inhibited, but the enzyme that is not inhibited will be sufficient to maintain the folic acid synthesis. Does that make sense? Okay? Enzymatic bypass. That's what we discussed in relation to TMP-SMX as well. As the adaptive mechanism, microbe can develop a different metabolic system that will work as a detour, right? Does that make sense? So if you have like pretty much, yeah. If you have an initial point and a final point and certain pathway that leads the microbe from compound A to compound B, and then you use the drug that blocks it, microbe eventually may develop the detour that will take it through the same route, okay? But your target is not going to work with that route. Does it make sense? And finally, target mimicry. That's the fascinating one. Imagine that you have some drug that binds to the ribosome. Okay? You good? Follow me? Imagine that there is a protein that looks just like the ribosome, but is not. So your drug is going to bind to that protein, but not to the ribosome. Detraction. I would call it a detraction. Okay? Does that make sense? So it is a detractor for the drug. So drug binds to whatever mimics the target, and the drug gets sequestered. Okay? It gets blocked. Does that make sense? You follow me? Okay? Good? Clinically relevant. Okay, before we move on, again, what do you... Yes, go ahead.
So the target one, like the last slide, it just like changes its structure, like
Which one?
disguises it, like the last one.
The last one.
Target,
Mimicry. So, let me...
so like
Okay. I like beer. Okay. And I come to a bar. Okay, and I want the bottle of expensive beer. But the bartender doesn't want to sell me expensive beer, and he wants to keep it for himself. So what he does, he takes the same bottle, pours cheap beer in it, gives it to me. So the cheap beer is masked as the expensive one. I'm getting tricked. Same for the drug. Drug enters the cell, and instead of binding the target, binds something else that looks like a target. Does that make sense? The target, absolutely. Bacteria is tricking the drug, and since drug is bound to that mimicking, it is bound to one molecule and cannot act on the actual target. Does that make sense? Okay? So, what I expect you to understand, I give you a description of some situation in the bacteria, and you recognize what it is. Am I talking about the efflux pump? Am I talking about inhibition of uptake into the cell? I'll answer. It's not available to inhibit actual target. Does that make sense? How would I word the question? Pseudomonas aeruginosa produces a molecule to which, I don't know, carbapenems irreversibly bind. This molecule looks like penicillin binding protein, but it is not one. So what it is? Efflux pump? No. Cellular uptake inhibitor? No. Drug modification? No. Drug is not changed. Target mimicry? Yes. Okay? Does that make sense? So you're going to have a sort of a situation. I read it several times. I want to make it as clear as possible, and you, during the exam, you can ask me, can you reward this? Can you draw the picture? Okay? Does that make sense? I'll draw the picture. I'll tell you, okay, here's the target, here's something else. What, and you have to recognize this. Because, look, the exam is to check your understanding, not to trip you over. Okay? And Michael asked about the efflux pumps. They use ATP. Right? So imagine that you overwhelm the microbe with the target, with the drug. And microbe pumps it out, but it has to use ATP. So, although microbe protects itself from the effects of the drug, it puts some evolutionary, some fitness disadvantage. It uses energy for that process. Does that make sense? I mean, if there would be no drug, yeah, ATP would be used for something else. But it has to, instead of replicating, it has to use ATP to pump out the drug. So it still has some fitness cost to the microbe. Does that make sense? I think if you overwhelm, yes. But again, it's the adaptive process. So I bet microbes will adapt to the concentrations of the drug that are therapeutic. Okay? Does that make sense? Resistant microbes. You have to know these acronyms. I give you an acronym. Blah, blah, blah stands for. Okay? So, what you're going to find in the hospital? MRSA. Okay, just, huh? Yeah. So, resistant to pretty much most beta-lactams. Definitely resistant to penicillin, VNG, ampicillin, amoxicillin, methicillin. Some of them may be more sensitive to carbapenems, but still they are increasingly resistant to all beta-lactams. They have penicillin binding proteins that has low affinity, which means the drug doesn't bind to the target. Does that make sense? So it's an example of target modification. Got it? Clear? Did I make myself clear? Target is modified, so penicillin and its derivatives do not work. It's a new normal. That's it. Nosocomial infections, community-acquired infections, causes pneumonia, wound infections. It's actually present in about, different estimations, 15, 20, 25% of the population in the nose, normally. And I have a strong suspicion that one of the students actually isolated it. I don't remember from where, from some environmental sample. So it may be growing. We most likely growing Staph aureus, and we're checking if it's penicillin resistant. It's going to be pretty exciting. Vancomycin resistance. Two major microbes. Vancomycin resistant Staph aureus, vancomycin resistant enterococci. Enterococci are normal components of the human intestinal microbiome. When they become vancomycin resistant in the hospital settings, they may cause urinary tract infections and wound infections and septicemia. And vancomycin is the great alternative to beta-lactams. Okay? Does that make sense? Great alternative. But if they're resistant to vancomycin, this alternative is gone. You can't use it anymore. This is another example of target modification. So peptides in peptidoglycan are changed, and vancomycin doesn't bind. It doesn't inhibit. Okay, so again, target modification. I'm gonna put this little target modification. Okay. Extended ESBLG negative. Extended spectrum beta-lactamase gram-negative microbes, which means gram-negatives means E. coli, Salmonella, Shigella, Klebsiella, Enterobacter, all kinds of intestinal microbes. As you can imagine, this resistance may arise from treating patients with different drugs against gram-positives like cephalosporins and different penicillins, and your intestinal microbiota will gain resistance to it, and intestinal microbiota is going to be spread, and that's very, very big contributor to the hospital-acquired infections. Okay, so these guys have beta-lactamases, the enzymes that degrade beta-lactam. Okay, so in this case, it's going to be a drug modification. Because in this case, it's a drug that gets destroyed. If I go too fast, let me know. Okay? We good? Now, these infections that actually also can carry some plasmids with resistance to other antibiotics, like aminoglycosides or fluoroquinolones or tetracyclines, these microbes are still sensitive, can be treated by carbapenems. And carbapenems for a long time were considered to be a magic bullet. Until recently, the carbapenem-resistant Enterobacteriaceae. Now, Enterobacteriaceae means enteric bacteria. Again, E. coli, Salmonella, Enterobacter, all those gram-negatives. Okay, a lot of it is Klebsiella. Okay, it is resistant to carbapenems. probably the most advanced beta-lactam antibiotic so far. Okay, it's something like 4th or 5th generation beta-lactam. They have a set of mechanisms. They have enzyme, carbapenemase, that breaks down the drug. So it's going to be drug modification. They have efflux pumps. I think it's self-explanatory. Okay, and they have altered porin selectivity. So this, what do you think altered porin selectivity means? What is the function of porins? In gram-negative microbes, porins are in the outer membrane. Think about the name, porin. What it sounds like. Pore, and it's like a hole, so what it's likely to do? Let things in. So when porin selectivity is changed, it doesn't let the drugs in. So it's going to be inhibition of uptake. Does that make sense? Okay. That everybody flipped out about carbapenem-resistant Klebsiella recently. That's the one we discussed. Did we talk about the one that originated in India? Yeah. So that's the one, and everybody was flipping out about this. It's really horrible because it's moved to the U.S. and now it's everywhere, and it's a really big deal to treat it. It's really hard to treat. And our lovely favorite one, Mycobacterium tuberculosis. There are several grades of resistance. MDR stands for, anyone can tell me without looking at the slide, MDR, multi-drug resistant. XDR, extensively or extensive drug resistant. And TDR, totally drug resistant. And when we say total, we mean total. It means that there is a strain of Mycobacterium that is resistant to rifampin, isoniazid, fluoroquinolones, kanamycin, tetracycline. I'm not even talking about tetracycline and erythromycin. All drugs. It is resistant to all drugs. And when I first heard about TDR, it scared the shit out of me, to be honest. Okay? Who are at risk? Well, everybody. But kind of giving you a heads up, humans are intrinsically resistant to tuberculosis. 5% of people who are actually infected develop the clinical disease. Estimation is that about 1/3 of the world population is infected. But we may live like in 90s not even developing TB. Does that make sense? So TDR, the totally drug-resistant mycobacteria, is extremely hard to treat. And treatment options are limited. I think what they do, they combine various therapies. It's a long-term, high-dosage therapy. So patient doesn't feel happy about it. And there was a famous case of the patient with the totally drug-resistant tuberculosis. I think he was in India. He was in India. He flew to the United States for I don't remember he was quarantined somewhere. So the point is, he did 2 flights from India to States, like there and back. I think it was from States he flew to India to like wedding and then flew back, although he was told not to travel anywhere. I know. No, it was definitely not a couple of months ago, like 2 years ago. There was a famous story, and they had to check the entire plane, well, 2 planes, passengers in 2 planes, whether they acquired TB or not. And I don't think anybody was happy about it. And, well, they treated the guy successfully, so they limited the infection at least. But it's extremely hard to treat, as you can imagine. So, and the problem, why it arises? Look, I'm not racist, but let's speak the truth. The problem with the public health in developing countries is what drives antibiotic resistance, period. Okay? I'm serious. Treatment for TB often includes 4 to 6 month treatment with antibiotics. You mentioned about the price. I mentioned the price. Even with the cheaper prices in developing countries, it's still expensive. If I go to the doctor and doctor tells me, look dude, 6 months, $50 a month. And I go to another one and he says, oh, 2 weeks, $5 a week. Which one will I choose? The second one, right? In 2 weeks, 2-week treatment with tetracycline will probably take care of most of the symptoms. It will also promote the development of resistance. Yeah, it kind of shut it down. It will probably remain in the macrophages. I will not be ever completely treated. But I have no symptoms of TB. I'm happy. And we have resistant strain of TB to this antibiotic, and then to this one, and to this one, and to that one. It comes from the lack of proper education of physicians. Because here, you cannot buy antibiotic without the prescription. In India, the prescription laws are much simpler. And to be fair, back home, I can come into the groceries, well, not the grocery store, the pharmacy, and I can buy antibiotics over the counter. Penicillin, tetracycline, well, probably not like rifampin or isoniazid, but most of the common ones, be my guest. And they dirt cheap. Okay? Oh yeah, to an extent. I mean, but look, now I'm kind of grown up. When I was a kid and I have respiratory infection, my mom would get some, it contained some sulfa drugs, Biceptol, and gave it to me. And I took it, and I got better in 3-4 days. Did I get better because of the drugs, or I just got better? I don't know. So I had my share in promoting resistance. Make sense? So having it on prescription is not a bad idea, to be honest, because at least it helps to control the resistance development. Okay? I want to talk about the stuff that we actually done, how we test therapeutic effects. Essentially, we make a culture, we throw in drugs. So what we did so-called Kirby-Bauer test, right here. Okay? So you have antibiotics in the certain concentrations that you place on the lawn culture of microbes. And you look at the size of the inhibition zone. Does that make sense? And you can say which antibiotic is more effective. But remember, each disc has a fixed concentration of the drug, which is usually clinically relevant. So you can say that, I don't know, this one is much less effective than this one against Staph aureus. Okay, and this is what? That's Pseudomonas. You see, only this drug is moderately effective. This is often used. It's a fairly simple method. It's used in the hospitals for so-called antibiogram. special teams in each hospital in the United States, team of clinical microbiologists go and swab everything in a hospital. Toilets, walls, floors, rails, whatever. And they culture it, do the pure culture, identify the microbes, put them on the plates, and test their sensitivity against different common drugs. So they know what nosocomial infections they can encounter and what they treat them with. Does that make sense? Of course, they don't do it every week, but they do it from time to time. I don't know the guidelines on how frequently it should be done, but they do it from time to time. The advantage is that it's relatively fast, okay, and inexpensive. Other alternatives is the dilution tests. Okay, you can do the 96-well plate, or you can do just the liquid culture. Okay, so you see how increasing concentration of antibiotic drug inhibits the growth. You have a growth at, say, 2 micrograms per ml, but you do not have any growth at 8 micrograms per ml. So you can see between which concentrations you have that threshold when drug starts to inhibit the bacteria. Does that make sense? The dilution tests. Same goes here. So you have, different dilutions, right? And you can say this has very high inhibitory concentration. This is fairly low inhibitory concentration. So this is the term I want you to know. Minimal inhibitory concentration. Can you explain it to me? MIC. Minimal inhibitory concentration. It is the concentration at which, minimal concentration, at which drug inhibits the bacterial growth. Clear? Is that clear? So to determine this, the great thing is the E strip. You see that one? Number 4. E strip is the piece of special paper infused with antibiotic. The concentration of antibiotic changes from very high up here to the very low down here. Okay? You see? High concentration, low concentration. This strip is placed on the bacterial lawn. You follow me? And high concentrations, of course, inhibit, and the zone of inhibition decreases and essentially disappears at the minimal inhibitory concentration. Does that make sense? So it's a fairly simple method to determine minimal inhibitory concentration of a specific drug against a specific microbe. Is that clear? Yes. No. Drugs can kill only replicating cells. Right? Endospores will survive, yeah. Now, but in the human, endospores will germinate right away. Now, let's say we have a drug, like a new drug, and we want to know if we should use it or not. Each drug has its own therapeutic index. Okay? To determine therapeutic index, we have to determine toxic dose and effective dose. Okay? So toxic dose, toxic, effective. Toxic dose, TD50, is the dose of a drug that causes toxic effects, causes toxicity in 50% of patients. Effective dose is the dose that effectively treats 50% of patients. Are those terms clear? Okay, is that you understand me? Two different doses. So toxic dose means 50% of patients have side effects, certain toxic side effects. Effective dose means 50% of patients are successfully treated at this dose. Therapeutic index is the ratio between toxic and effective dose. So if you have a drug which toxic dose is in some units 100 and effective dose is 1, what's going to be the therapeutic index? Ratio. Toxic dose is 100, effective dose is 1. What's the therapeutic index? If it's the ratio between the toxic dose and effective dose. No, it's 100. 100 divided by 1. It's a ratio. Does that make sense? 100 divided by 1, which gives you, okay, we have a drug which toxic dose is 100 and effective dose is 2. What's the therapeutic index? 50. Does that make sense? Right? Which one's better? Higher therapeutic index or lower? Higher. Why? Exactly. Very good explanation. Very good explanation. We have more leeway to increase the dose. Does that make sense? If your effective dose is 2 and your toxic dose is 200, you have all that space. You can increase the dose without poisoning people. If your effective dose is 2 and toxic dose is 3, that's it. You can't raise it anymore. There was a famous case of, I love that example of therapeutic index. There was one drug against some equestrian disease, which therapeutic index was 1. What does that mean? No. Therapeutic index equals toxic dose divided by effective dose. If therapeutic index is 1, what does it tell you? Therapeutic dose is equal to effective dose. So they gave the drug to the horse and the disease went away in 2 hours. In the morning the horse died. No, I mean it was a trial, but it's a therapeutic index of 1 means that yes, you're going to cure disease and the patient is going to be toast. Okay? I will ask you the question something like compare two drugs. So if one drug has a therapeutic index of 10, another one is 100, which one's better? 100. Does that make sense? Okay.